The Philippine Nurses Association of Nevada now brings you FilipiNARS, news and features about the Filipino-American nursing community and beyond. And now, here's your host, Doris Bauer.
Well, hello, FilipiNARS listeners and followers. I hope you are all doing well. Thank you so much for joining us today. And as you know, of course, FilipiNARS is brought to you as a public service project of the PNANV, or the Philippine Nurses Association of Nevada, in collaboration with PHLV Radio. So this program is disseminated in different social media platforms such as Facebook, YouTube, iHeart, and Amazon Fire TV. And it is also shared in our association's website at PNANV.org. So there you go. Okay, so we have a very interesting topic today. And so everyone knows really about hospice care, which is a type of healthcare that focuses on assisting the terminally ill, attending to the palliation of their pain symptoms. This type of care focuses on attending to the emotional and the spiritual needs at the end of life. And most of the knowledge that we really have is hospice care for adult patients. But what about the kids? Is there really hospice care for the pediatric population? Well, there is. And here to talk about Pediatric Hospice are our guests from One Care Hospice, Ms. Courtney Kaplan.
Hello.
And Ms. Desirae Santiago.
Yeah.
So Courtney Kaplan, who is my friend and I've been known forever and ever, she is the Director of Community Relations of One Care Hospice.
Most definitely being with a pediatric palliative program, being with One Care has been by far the most rewarding. I had found myself in a very similar situation 4 years ago with the loss of my own son, and experiencing that emotional trauma and having to live with grief through the rest of your life. And how do you continue to live when a part of you has died? You know, that dynamic of how do you do that? I'm certainly not the poster child of that, but I will say that through my journey, I feel I have gotten some little nuggets and just little ways that I can kind of help support other families who possibly may be facing, you know, what I'm going to be living through the rest of my life. And, you know, if their child happens to not have that result being transitioning, but do need a lot of support because they are, you know, physically and medically fragile.
Right.
I feel like I could bring a little piece of my heart and my soul and my story with me. So that is why I have landed with pediatric palliative care, and it is the most amazing experience of my life.
Very good. My hat's off to you and the caregivers of hospice, because honestly, I don't know how I would handle that. So
we hear that a lot,
all the time.
I'm telling you, that's the first thing. How do you do that? It is. That is the question.
So our other guest is Desirae Santiago. Desirae is a master's in science, and she is what we call a CCLS, which is a certified child life specialist.
Yes.
Okay. Desirae, can you tell us a little bit about yourself?
Yes, definitely. So I have my master's in child life. I've been living in Las Vegas almost all my life. So as a child life specialist, I'm trained to help children, siblings, families cope with medical diagnosis, medical education, coping with grief and loss, dealing just with a medical environment, especially not only in the hospital, but now at home. So helping them just cope with what's going on, and just trying to normalize it as much as possible. And explaining to children in a way that they can understand what's going on. Because sometimes as adults, we talk to children thinking they know what we're saying, but they're not quite there yet. So just finding ways through, you know, education, play, art, to help them understand what's going on in their lives, as well as to express what's going on and how they're feeling.
Very good. Well, welcome, ladies. And when you talk about pediatric hospice in that population, you're talking about young children and adolescents as well, right?
Yes, the pediatric hospice benefit is for 0 up to the age of 22. So at the 22nd birthday,
I see.
That would then need to transition either to adult care, adult hospice care, or if there were other needs besides hospice, we would be able to work with the families on that.
Okay, which you basically answered my next question to you is, what is pediatric hospice care and what does it encompass?
Sure. Pediatric hospice care, in a nutshell, is really any child, again, from 22 under, who is facing a life-limiting illness or a life-limiting injury, that if a certain treatment or therapy that they're receiving was withheld, would that cause their ultimate demise? So whether that be chemo, we've got so many children that have genetic disorders, trisomies. I mean, the list is just extensive. Seizures disorder, any of those things.
Congenital heart malformation.
Oh my gosh, we've got so many cardiac babies, cardiac kids, young adults that just are medically fragile. And typically you don't just have one little, like you have a diagnosis. This is a range. This is comorbidities. This is a whole system failure at times that we are addressing in the home with these families.
Right.
So the qualifier really is that if you have a life-limiting illness or injury that, without treatment, you would, it would cause your passing, that is what would qualify you. The doctor then does sign that order, just like a hospice patient, same thing, 6 months or less. With pediatrics, a little different. Although the doctor does go in and have to recertify during those recertification periods, as long as there is a documented decline of some kind, we can keep our kids on for a very long, extended period of time, treating them as a whole.
Okay.
We basically come in as a case management service and monitor and maintain all the other complicated things that are going on in the kids' lives. So that's where it's different than the adult.
Yeah, that's what I was going to say. That's where it differs. There's no limitation.
There is not.
On the time factor, like say 6 months or whatnot. So is that what the adult hospice is all about then? Yeah, well, it is. Any hospice service, whether it is pediatric or adult, you do need to have a certification of a doctor saying, within my best guess, this adult or child has 6 months or less to live. That is required. That's required. For both lines of service. What differs is the level of qualification that where an adult, we have several cert periods, just like kids. There are some adults that are recertified. They can be on hospice for 2 years. I've seen it, for 2-3 years. Again, as long as there's a documented decline. But with kids, there is what's called, it was part of the Affordable Care Act in 2010, where the law changed and we were able to provide now curative care and supportive care for the ages of 22 and under. Okay. And that's where we come in with, it's called concurrent care. The children can receive aggressive treatment and supportive care. Okay. Through their life-limiting illness or injury. Okay. So aside from that, what are the other qualifiers to be in hospice as a child or pediatric hospice? Sure. Really, it comes down to that, the comorbidities. It comes down to if this therapy or treatment was not provided, would this child, pass from the injury or the illness? Those really are the qualifiers. And the list is very, very long. There's neurological, there's cardiac, there's chromosomal, there's genetic. My gosh, there's GI, cancers. I mean, the list is so very long. So very long. Very good. And, preemies,
who are coming out with just a failure to thrive in general and just are having a really hard time, outside the womb, with all of those treatments and therapies and medications and things that these kids need to keep alive.
Alive, right.
We can do all of that at home.
Yeah. Good. So, Desirae, what is the goal of pediatric hospice care?
So the goal of the pediatric hospice is providing a level of comfort in the home, trying to alleviate and take away some of those multiple hospital visits. There's something that we can treat at home, and then our nurses and our staff will go in and be able to help assist at home. Or if it's something that we cannot do at home, then our nurses will recommend sending the children to hospital for further treatment. So really it's just adding a supportive surface and adding that level of comfort.
Okay. You have anything to add to that?
Definitely. She worded it very well. It really is about keeping the families at home where their best chance of survival and thriving is at home with their own germs and their own families and their own, all of that love and support that you get, from your home and family. That's where, a healthy life is, and keeping our kiddos home however long we can. Whether that's some moms and dads, they choose because of the severity of the illness. We've seen kids go home from the hospital, from the NICU, let's say, and there is just really not a chance of survival. So the families will choose to come home, and we will withdraw life support basically at home, surrounded by their family.
Yeah,
I mean, that is what
better.
it's about.
Right.
If that is where it has to go, and that's where it's going, that's where we come in with our whole team, the doctor, the nurses. We come in with Desirae and just pour what we can into this family. And aftercare is so important too.
Yeah.
Oh my gosh.
Right.
It isn't just, hi, thanks for coming, bye-bye.
Goodbye. We're done.
It isn't like that.
Which is really, what gives this program the credibility and the comfort that, they families are asking for, right?
Absolutely.
So how would you initiate that conversation to a family, knowing the diagnosis, knowing where they're headed, the child is eventually going to die, be terminally? How would you initiate that conversation?
So most often the conversation is initiated when the kids are still in the hospital. And a lot of the times the physician at that time will say, this is where we are, this is our recommendation, and they usually recommend hospice at that time. And so, our liaisons will also go talk to the families about what we offer at their home for them. Me as a child life specialist, when we have children who come on who are on hospice status, I meet with the family to gain their understanding and how they are coping with, do you want your child to be at home peaceful, or are we still kind of in a denial phase? Are we still not really sure where this is going to go? So it's just really understanding what the family understands. And me talking to the children, it's also saying, what do you know? What do you know about your journey?
Yeah.
And I do have kids who absolutely know there's nothing that can be done.
So of course you have to involve the kids.
Absolutely.
If they are
Absolutely.
age.
So just understanding what do they know and saying, so they're accepting of it. Now, what do you want this to look like? Do you want to be surrounded by family? Do you want to have your favorite blanket on you? Do you want a certain kind of music? Do you want a candle lit? Who do you want in the room with you? As a child life specialist too, I do what's called legacy building. So I do handprints for the family. So that way, when this child does pass and die, the family will have a keepsake that they can carry of their child. And we create that there in the home. I put a lot of love and care into my keepsakes. All of us child life specialists have our go-to of what we want to do. And just in my timing at One Care, I've really developed something, what I call a handprint plaque. Sometimes it'll involve just the patient. It might involve the whole family's hands. I put, flowers, and I epoxy it. And it's just something to really have the family hold on to once this child does go.
Yeah, and you have to be straightforward with them, right?
Yes.
Straightforward, and it involves also talking to them. Also involves involving everyone.
Absolutely.
Actually, getting and of course showing respect for their relationships.
Definitely, and it's providing opportunity for closure for these families.
Now, in your experience, have you seen anything like say, denial from either one, like from either the parents or the kid.
Yes.
So how do you handle that?
So I've seen that actually a few times, which I think those are sometimes the hardest cases for me. Because, I've seen it where the children knows what's going on and then the parents are not quite ready. So it's really educating the parents. Although it can seem very brutal, as I always tell, my coworkers and my families, I'm not trying to scare you. I just want to give you the reality of the picture that we're painting. If we go the CPR route, this is what's going to happen to your child. They're going to come, they're going to bang on your child's chest, they're going to, bruise their body, and your child may die with strangers around them. Versus if we do the DNR route, let's provide it with them in your arms. Let's be comfortable and peaceful. Let's not expose them to strangers at that time.
Right.
So a lot of times it's education. Some parents say, you know what, you're right. Let's do the DNR. And then some parents are just not there. They're not ready for it.
Yes, that to me, that is really very difficult. So in the more acute care setting, which is basically in the hospital, they have a chance to prepare. There's called advanced planning and kind of stuff. So in your area, which is in home care, when you get these patients, do they already have a DNR, or DNR is do not resuscitate for those of you who are unaware of that. So do they already have a code status?
They don't always have the DNR. Usually it's when we admit them, we're going in and talking to them about it. And at that point, we'll usually sign the pulse forms, and the doctor will sign off on it. So then that helps make things a little bit smoother. But again, there's a lot of times where people are just not ready for the DNR.
They're not ready.
So we just kind of have to keep going as far as the care and comfort, and just continuing to educate family. This is where we're leading. We're getting closer.
So even if they do not have a DNR signed, you still can accept them to hospice care?
For sure.
Correct.
Okay. Adult and children.
Adult and children.
And children, both.
Okay. All right. That I wasn't really quite certain of. Okay. So that's really very good information for everyone.
Oh my gosh, yes.
Yes.
It's underutilized. I think it is one of the most underutilized
That's what I was going to ask
parts of medicine that we have here, and it is funded by Medicaid. I mean, that is 99.9% of our payer sources is Medicaid, Nevada Medicaid, and I know that people have their opinions about state insurance. I understand.
Correct, yeah.
But I will say this: this program and the ability to provide continuity of care and concurrent care, where we're doing the comfort and the education and just pouring love into these families while the end date is unknown. It's not we're not focusing on when. We're focusing on really educating these families to live in the moment.
Definitely.
It's day to day, moment to moment.
Yeah.
Because you're going to miss that moment when the when comes. There's always that, well, how long do you think they have? There's always that, when are we going to get there? Because you really it's a trauma, it's a preparation. We're humans, and we want to know, when's the next shoe? What do I need to do next? That's just us being humans.
Of course,
but really,
yes.
it's that family support, and our program is just going in there and look, you've got today. You have today. Let's make something of it. Let's love it. Let's love together. It's really just re-educating and supporting the family through that.
Well, that's what we're here for, is to try to educate the public
please.
and our caregivers, right?
Oh, yes.
Yeah, because this is, like you said, it is available through insurance, and it may not be everything that you need, but at least some kind of service is provided, correct?
Yes. In addition to pediatric palliative care, there is also what's called private duty nursing, which is a custodial care nursing. This is again not visits where we go in and do wound care once a week kind of thing. Private duty nursing is a program that provides families who have these medically fragile children with ventilators, trachs, G tubes that are just trying to be home and be a family. We can be in the home along with their nursing program. It isn't a choose. They can have both. Where they can get a nurse up to 112 hours a week at bedside in the home, and we come in and we add another layer of home support. So it is just an underserved, underutilized, just a lot of, again, education. It's education.
Right.
It's how does my child qualify? How do I get a hold of somebody? How come I've never heard of this? And it isn't anybody's fault.
Right.
We've got pediatricians and doctors and specialists doing the best they can. And we're out here trying to tell them, hey, we're here. So this is so helpful for families that are at home with medically fragile children, and they don't all have to have vent, trachs, and G tubes.
That's what I was going to ask.
It
it's
isn't
still
that
acceptable that
it's
those
acceptable.
kids or those patients who have ventilators and they still would qualify
They
for
would,
the service.
yes,
right?
they
Absolutely.
would, they would, and they do.
And it's definitely also to reassuring parents, not all kids on our service are hospice status. Some are just that palliative care, needing
Exactly.
that care. Yeah, and that scares parents sometimes. Is like, whoa, my kids aren't hospice. Well, no, they're not hospice. That's just kind of the umbrella. But no, there's the palliative care side, and then there's the hospice side. So it's also just providing that comfort to parents. No, your kid's not there.
Right.
We're just here for what's going on right now.
Right. Okay, so tell us about One Care Hospice, your agency. I mean, you've mentioned some of the services, but in a nutshell, or
Absolutely.
explain to me what the services are.
Sure. So One Care provides in-home specialist, a nurse who specializes in palliative comfort care. All of our nurses have been trained in how to identify symptoms, how to manage them. And the beautiful thing is we have a doctor, literally all of us have our doctors in our phones. We text them and this is what's going on. We feel like adding this medication or would be great. This is where having our services in the home for these medically fragile kids who don't have to make an appointment with the pediatrician, then call and make an appointment with so-and-so and hope that you get in at least 2 months. And then it's just really, that's the reality, right? That's the reality.
Right.
We literally have our physician on text, literally, boom. We can get whatever intervention into the home It's immediate. As long as it takes the pharmacist to mix it, make it, it is in the home. That is how long it takes. If it's a pharmacy thing, if it's a therapy, if it's a handy dandy device, a chest, a compressus vest, whatever it is, we can get that done almost in an immediate fashion because that's how quickly it works. So the doctor and the nurses coordinate that care. We have a social worker department who specializes in resources. I mean, who doesn't need those?
Right.
I mean, we're dealing with life-changing events, moment to moment. Families are like, oh my gosh, this just happened. I couldn't pay my electric bill. Kids on a ventilator. I'm just saying those things happen.
Yes.
The social worker goes in and helps get them connected with Nevada Power's program that this house just cannot ever lose power, or whatever these services are.
Right.
If it's funding, food, oh my gosh.
Right.
Transportation, I mean, we've literally heard it all. Social worker goes in and makes sure that this family has the resources that they need. Applying for Katie Beckett Medicaid or whatever those things are, they are there. We have a great volunteer program. Some families do like to use volunteers, some do not. We've got the personal care with like the CNA or the hospice aide. Some families like to do it themselves, some don't, so we have that service.
Right.
We always have our bereavement and our spiritual department who pours that part of their journey if they would like it. And again, these are all services that are by choice. We do absolutely have to have the physician involved and the nurse.
Of course, right.
But any of those other child life specialists, some families choose them and some don't.
families
And that's okay.
Absolutely.
That is absolutely their
Sure.
right.
It is their right.
But at least here's our hand, here's our cards.
Right.
Pick
right.
one, pick them all. Like, this is what we have for you. We are in constant contact with them during their journey and after. Whatever that looks like.
Right,
we
right.
continue to remain involved.
Okay.
And we can service patients in Reno. We can service patients here in Las Vegas, Boulder City, Pahrump. I mean, we've got a really long reach, and soon Phoenix will be opening up. So for your
Very
listeners
nice.
that are just everywhere, we're right around the corner. And if there's ever any questions or what do you think about this? Because my child used this or that. I want to make sure that your listeners have our contact information.
Yes,
Because
yes.
it's about education. It's about asking. You're not alone. You're not
Correct.
invisible. You're not missed. We're here for you.
That's pretty awesome. And those services are really, it gives the family some kind of comfort that, the things that are going on in your head when someone who's close to you is about to die
Yes.
or in that end of life stage, you just don't even know where to put yourself, right? So
That is
these
so
are
true.
wonderful services that you provide. So you have, let's see, nurses. You have the physician, of course. You have nurse aides.
Yes.
CNAs,
Yes.
CNAs. You have
social workers,
social worker,
our
life.
chaplains,
Yes,
and
the
then the
spiritual
child life
side.
specialist.
And the
Yes.
child life specialist. Okay, that's good. So what type of medications would you still allow for the child or the pediatric population hospice? What can they receive
Sure.
and what can they not?
So I would say that there really isn't a not factor. Honestly, even if it involved the child needing some kind of, like, say, TPN, like an infusion,
Right.
and or some kind of pain pump, or one of those medications that without our service may not be accessible in the home, with narcotics and things.
Yeah.
Hospice has the ability to provide those medications that many of the physicians are actually kind of unable to really provide just because of how it is out there.
True.
There's a spotlight on the use of those kind of medications, and a lot of the physicians are not comfortable doing that. And we get that. With hospice, we fall under a whole different umbrella, and the our physicians have the ability to write for those barbiturates, or if they need narcotics, if they need a pump, any of those kind of medications.
You still do tube
Absolutely.
feeding.
Tube feedings.
Tube feeding.
Tube feedings, TPN.
Antibiotics? No.
My gosh, yes.
Oh, good. Oh, good.
Absolutely. Catheters. Anything that this child is already getting. And again, a lot of them are still receiving chemo. Mm-hmm. So they've got nausea. They have illness. They're ill inside. They're tired. They don't feel well. All of those things that go along with that, our physicians can monitor that and order that alongside their oncologist. So it isn't I have to choose? This is the beautiful part. You're just choosing life.
Yeah,
you're choosing
you're
comfort.
Right.
It isn't, do I have to choose this type of service or this?
It's a more collaborative approach with their specialist.
Really is.
With their specialist.
Yeah, it's a more
Okay.
collaborative approach with
Absolutely.
their specialist.
So if you assign a nurse for that particular patient, does she finish the case, or do you have the capability to assign someone else, or do you tag team? What do you do?
Usually, we always try to have the same nurse follow them, but sometimes, as
for continuity.
yeah, as best
for
as
sure.
we can. But as sometimes nurses have to switch around, or
Yes.
maybe we have a nurse on maternity leave or something of that sort, or
right,
vacation,
right.
and one of the other nurses will step in. We all collaborate really well together and communicate really well together, so we're always on the same page. We have biweekly IDTs where we go over all our patients to see where they are, what their needs are. So it makes it a little bit easier that we're already in the know.
In the know, right? Correct. Okay, so Desirae, the family would be choosing the location where their child is going to pass, right? And do your staff go to these locations, and if they're not in the home as well?
So
or?
usually they're always in the home.
That's what I was going to say.
Usually they're always in the home.
Okay.
There's sometimes kids might go for respite care, like at Neurorestorative or Silver State. So at that time, they're no longer on our services just because we're not contracted with them. But again, we're still very communicative about, like, you know, if they're in respite and they come back, okay, hey, this is how they were when they were away. This is how they're coming back to you. And okay, we'll just pick up where they left off. So again, it's just definitely giving a lot of that collaborative approach with the community. But yeah, usually they're always at home.
So if they go into some kind of facility for respite purposes, you have to discharge them from your care.
Correct.
But then when they have to go back, then you will admit them back.
Correct. They'll just put them right back on service.
Okay. And that's because of probably the
It's billing.
It's
It's billing.
Correct.
It's a duplication. Yeah, it's billing.
Yeah. Okay.
And these families, they do bear the burden.
Right.
And the benefit, you know, of being at home, you know, with their child. And as we all know, there's caregiver burnout. This is a real thing.
It's a real thing.
It's a real thing.
It's true.
And if any of you have caregiver burnout, there is help out there. There's hope. There is rest for you.
It's called respite, correct?
It really is. Not only for the parents, but also for the child.
For the
You know,
child.
let mom recharge. Let her plug in, let her get her battery back up so she can be the best mom and go home and take care of you again. I mean, my gosh.
And sometimes this child is not their only child.
So many times. Oh my gosh, Desirae, for sure.
So many times. And there's some parents who have multiple children who are medically fragile.
Yes, we have those as well.
We have many families who have multiple children who are medically fragile.
So the respite program gives the parents or the caregivers to take a break.
Yes.
Yeah.
Take a break.
Absolutely.
Take a break. Go home. We have a couple of families that'll have their child go to Neurorestorative for a couple of weeks so they can go back to their homeland, Mexico or Philippines, whatever, and go see family and come back and pick up where they left off.
Take care of their own medical needs, their own mental health needs.
Yes.
True.
We've had
Very
those
good.
come up too.
Very good. So, what other insurances takes hospice or no? What other insurances provide for hospice pediatric care?
Sure. I would say the majority, again, would be our Nevada Medicaid. And they also have Nevada Medicaid, and then they have the MCOs, they're called. So like your Smart Choice and your Anthem Medicaid, like even those plans, any of the Medicaid plans are 100% covered at no cost to the families.
Okay.
A lot of families do have private insurances as well.
Right.
And many of those do cover hospice, just in general. There aren't a lot of kids on with private insurances, not a lot. So we are still working with insurances to kind of make sure they understand why we're billing, what we're billing every day, what we're including. It's really just an education process. But also TRICARE. TRICARE is an amazing resource for our veterans, for our active duty, for our retired. I mean, we definitely have TRICARE, and they are very, very gracious, recertifying our kids and making sure they have everything they need. So TRICARE is another one that we definitely see a lot of. And even, you know what, we've done a good handful of pro bonos. Absolutely. I will be honest with you, Doris.
Yeah,
definitely.
I know that we all have to make money. We're all in business. I get that.
Yeah.
But there's also that opportunity of giving back and making sure that a child, that you get one chance. You get one chance to do it right. And if we can be there to support that family through that journey, because it is lonely, it is scary, it is painful, we definitely do that as well.
And, my hat's off to you guys for doing that. And I know, a lot of the agencies try to do that as well, because this comes to, the discussion of, it's healthcare disparities with race or with income, financial income, that always comes into play.
Always.
But just talk to these people, talk to your hospice provider, talk to you guys. So, I have another thing. So how do you talk or prepare the family to deal with some certain end-of-life issues? For instance, organ donation or funeral arrangements. How do you, autopsies, how do you initiate that conversation? I know that's kind of difficult, right?
It's definitely difficult. Our social workers are really good about helping, and even our nurses too really are good about helping families pick funeral homes. So we have like a list of funeral homes and mortuaries, and what do you want? We usually write it down. We have it in a folder for them. When the time comes and the family is ready, we're usually in the house with them to pronounce the child. We will help clean up the child. If the family has a certain outfit they want their child to go in, we're going to treat them with dignity. So we're going to put them in that special outfit. And when the family says they're ready for us to call, we'll call. So if the family wants just, an extra hour before we call the mortuary or the funeral home, we will sit there with them, give them that extra hour. And when they say they're ready, we will be there with them as that child is walked out with the mortuary or the funeral home. Right. And we're there to comfort the family. So again, it's just educating on what's out there. There's so many foundations, especially in the pediatric oncology world, that help pay for funerals. Candlelighters, Nevada Childhood Cancer Foundation. So it's connecting them with also those resources to help them with those funeral costs. And just doing our best to support them. As far as autopsies, I generally don't really have kids who have autopsies.
Right.
In this case, in these specialty. And then as far as like organ donation, again, if that's something the family should choose, and then usually they're in the hospital about that time.
Yeah. Okay.
Yeah.
Yes. Okay. So there's a lot of emotional preparation.
Yes.
And just a respect to the family as to what they really want to do.
Absolutely.
And how they want to let go of the child.
Absolutely. And,
for sure.
after, again, we were talking about the bereavement services part of it, we go in and we check on the families. We text the families, the parents, see how are you guys doing? How are the siblings doing? I go in a lot of times and I'll work with the siblings and see how are they coping? How are they adjusting to this new normal of losing somebody they love, their brother, their sister, and just following along with the families, and telling the families, if you feel your child is struggling, if you're struggling, let us know. We'll come in and see you, We had a family recently, a mom recently, after her child died, went to check on her, and the mom was so sweet. She made us a whole lunch, but she just needed somebody to care for, and she just needed that communication. So it's like having a family dinner with your parents. We really end up becoming a part of their family because we meet their extended family. We see their home, we see their rooms, we see their pictures. So it's really following along for that continued support after.
Mm-hmm. What kind of issues or problems or challenges have you encountered with the siblings of the dying child? What are some of their issues?
Regression, sometimes behavioral, acting out, not really finding how to express themselves. It's very common too. You get a lot of siblings, even when the child is alive, saying, well, how come he's getting more attention? How come she's getting more attention? So it's really just, again, me as a child life specialist, finding ways to have that one time for the siblings where they can express themselves, how they can understand better about what's going on with their sibling who is requiring more needs. So those are probably the most common. And just, helping them cope and express with grief. Grief is a complicated feeling.
Right.
So just really working with them so that way they can find ways to, okay, what's my next step? What's my next step? Again, we have one day, what's the next day?
Right. Right.
So, okay. So you are okay with preparing the family. What about your staff? I know this is sometimes emotionally taxing to
my gosh,
them.
yes.
And to all, what kind of service do you offer to your staff? Mental health wise,
for sure.
Support.
Super good question. Again, we talked about caregiver burnout. We are no different.
Yes.
We have our family that we work with from 8 to 5. We're at work, and then we've got to go home too, and manage all of that stress and things, which can be a huge burden. So we have a support group that is offered through our bereavement program, not only for our families but for our staff. They are absolutely available, open door policy, if ever anybody needs to vent, talk about something, whatever that may be. That's within our own agency. There are several outside support agencies and resources and things. One Care is very, very aware and will provide a lot of like retreats or employee gatherings, or we'll have a food truck for you at least once a month. It's probably more than that. Or we just rented out a theater. Bring your families and let's go watch a movie together. Whatever that is, I mean, and I've. It's amazing.
Yeah.
And you get that camaraderie like soldiers, you need to be with each other. And just either talk about it or don't. Whatever it is that you need to do, just be where you're at the moment.
Right.
But absolutely, we've provided tons of services for our staff and make sure that we're healthy, because we can't really provide too much if our cup's empty.
Exactly.
Yeah.
We can't really pour, because it is emotionally draining.
Absolutely.
It is.
Absolutely.
If you're not in this because your heart made you do it, then please just don't do it, because your families are relying upon you as you are literally a limb for them, a crutch. You're there when they have no air to breathe. That's why you're there. And you've got to really take care of yourself.
Absolutely.
And we're really big too about after a death is all of us getting together in the conference room, meeting, okay, how are we feeling? How do we feel this
sort
went?
of a staff debriefing?
Yes,
staff debriefing.
very much so.
Yes, definitely. How
I'm
are
so
we
glad you
each
mentioned
doing
that.
individually? How are we doing as a team? Should we change anything for the next time? Can we do something better? Did we do everything we were supposed to? And just how are we checking in with the families after that? So, really just coming together and checking on each other. I've hugged so many of my nurses who have been crying, or they've held me when I've cried.
That would be me.
Yeah.
And, I think too, we also are really good. We know each other's families at work. So sometimes it's like checking with our spouses. Okay, hey, how's so-and-so doing? Or, let's get together this weekend and let's just kind of debrief a little bit with each other and have that like normalcy.
I get you. Okay, so One Care Hospice, where are you guys located? Give us the phone number and contact information.
Sure. Our office is on 3087. We've got several buildings, actually.
Okay.
And Desirae probably would be best. Which building would
The 3087
East Warm Springs.
Yeah, that would be
okay.
Suite 100.
Suite 100.
Correct. That's Suite 100 and Suite 200.
And Suite 200, and that's in Las Vegas, Nevada,
Correct.
89120.
Correct.
And the phone number is 702-463-1011, right?
I
looked you up.
use
I have so many numbers in my head.
I'm email and Teams and texting. It's like, Desirae, what's our number?
Let me take this.
Honestly, our families know more our cell phone numbers
do.
than the office. So that's
Exactly.
we're easily accessible to our families because of our cell phone numbers.
All right. So, ladies and gentlemen, One Care Hospice is located at 3087 East Warm Springs Road, Suite 100, Las Vegas, Nevada, 89120.
Yes.
Their phone number is 702-463-1011. And I think we can put this up on screen. If you need any admissions, you can email admissions@onecarelb.com. Okay. Got it. All right.
Yes.
Good. So, one final question. What is your message to the community regarding hospice care?
Honestly, the first thing that comes to mind is that you are not alone. That is the bottom line. You do not have to go through this journey. You don't have to, your journey doesn't end when your daughter or son transitions, whatever that may look like. You are never, ever, ever alone. And as a grieving mother myself, knowing that there's somebody else who knows what that hole feels like, and sometimes finding hard to find the air to breathe and get up out of bed. When you have someone else that gets that, there for some reason it's just like, you know what. Thank you. Like, I feel like it's a big relief. It's an acknowledgement. It's a validation that this is so hard
that you can't do it alone, right? Yeah.
Yes, that would be mine.
Yes. Definitely mine is, if a family is curious if they are eligible for the services, reach out to us. Let our liaisons educate you on what we can do for you. See if this is a fit for you. And again, we are here if you want us to be here. And we're going to always be your helping hand as long as you want us on your journey.
Yes.
Very good, very good. Well, Courtney and Desirae, thank you so much for coming to our program today to talk about this very sensitive topic. I know this is a difficult subject to tackle for most people, including myself, actually. So thank you for all you do. Thank you to all the healthcare workers who are with your agency, and for the healthcare workers who are in the same healthcare field, caring for hospice patients. Thank you so much again.
Thank you for having us.
Okay. And to our listeners and followers, we leave you with this. The final hours, days, and weeks in the life of a child or an adolescent with a serious illness is so stressful for families, for the pediatric caregivers as well. Some children die unexpectedly and suddenly, and others die after years of serious illness. And so as a healthcare professional, familiarity with the medical, emotional, spiritual, and logistics element of the end-of-life care prepares you to be a comforting guide for these families. Thank you so much for joining us today. Thank you for giving us the privilege of your time. This is Doris Bauer, your FilipiNARS host, signing off for now.
The Philippine Nurses Association of Nevada has just brought you FilipiNARS, news and features about the Filipino American nursing community and beyond.